Hello again, boys and girls. Welcome to our fifth and our final video. This one is on a variety of disorders: somatic, dissociative, eating, and personality disorders. You've got your key vocab on the right-hand side. We're going to go quickly through sort of a lot of other kind of just general categories of disorders, some very, very interesting ones in here. Let's get after it. The first one we're going to talk about is somatic symptom disorders. When you hear the word somatic, this has sort of a Latin root to this, to get into English for a sec. Somatic, dealing with sleep, dealing with things that are happening sort of below the surface. So if these symptoms are happening below the surface, these symptoms are being caused by something that is not entirely obvious. That is what somatic symptom disorders are dealing with. In other words, these are disorders in which psychological distress results in physical symptoms that don't have any apparent physical cause. So an example of a physical cause for a physical symptom would be you are not feeling well, you have an upset stomach. A physical cause for that would be that you have the flu virus in you and you are fighting off the flu virus, thus you are puking up your lunch. That is a physical symptom with a physical cause. If you do not have a physical cause, you might have a somatic symptom disorder. There's really two big ones to know about this. The first is conversion disorder. In conversion disorder, a person is having symptoms that really don't have any physiological basis. There's no reason to be having these symptoms that you have. So for example, you maybe have a deep sort of pain in your chest and you don't know why, and it's not a heart condition, it's not, you don't have any sort of lung or cardiovascular issues, you don't know why you have this pain, this pressure on your chest, but you do. That would be a potential evidence of conversion disorder. Two of the most common instances of this are blindness and paralysis. So in other words, someone wakes up blind with no real reason. Like you might be blind because you got hit in the head, or you might be blind because the nerve that connects your eye to your brain is degenerating. But that's not happening here. You have no physical reason to be blind. You just are. Similar, paralysis is something similar. It could be paralysis of your whole body, so you cannot literally move any of your body. Or it might be paralysis just of a part of your body, a leg or an arm or a hand. Both of those would fall under the umbrella of conversion disorder. One important thing to note about conversion disorder, though, is that it was much more common specifically in our old buddy Sigmund Freud's time than it is today. Conversion disorder is very closely associated with the psychoanalytic school of thought. This belief that, in fact, these symptoms that didn't have any medical or biological cause were actually being caused by unconscious anxieties, unconscious processes, the id going crazy, something like that, which resulted in these symptoms. Again, we don't see conversion disorder very much today. The second one, though, we do see today. This is illness anxiety disorder, and this is when you interpret just a normal, typical physical sensation as a symptom of some terrible disease. To give you an example of this from my own life. So when I was little, I was a swimmer in high school, and you would occasionally be really fatigued. Your muscles were really broken down. You just feel exhausted. And occasionally, some athletes watching this will know, if your muscles are super fatigued, they might twitch randomly for no reason. And when I was younger, occasionally I would get this twitching in like my arm or, in my side and my legs. And I would think, oh my God, I've got some kind of cancer that's causing my body to freak out and do these random weird things. If you have that ongoing, and if that becomes maladaptive for you, then you have illness anxiety disorder. This used to be called hypochondriosis. You'll still hear sort of culturally, we refer to what's called a hypochondriac. And a hypochondriac, meaning someone who has hypochondriosis, would be someone who is exhibiting these symptoms, who is imagining sort of serious illnesses where there really aren't actually serious illnesses. They're just random kind of minor physical things that are just part of our body's functioning. if you are around people who will sympathize with you when you present these symptoms, so in other words, if you freak out, if I had freaked out when I had some weird twitch in my arm, that would have been more likely to feed into my illness anxiety disorder, to make me more likely to sort of spiral in, to ruminate on that, and to keep letting that spiral in my mind until it became worse and worse. Luckily for me, I had a mother who just said, "Shut up, you're fine, don't worry about it." And so I never developed the disorder. Second big one, this is another fascinating disorder, dissociative identity disorder, also kind of more commonly known as split personalities, which is a real thing, as this lovely picture will demonstrate for you. This is when a patient exhibits two or more distinct and different personalities. So you are literally two different people at different times. Very often, this is basically like two or more, it could be more than two, people are living in the same body. If you, let's say personality A and personality B are characteristic of the same person, the person who is personality A won't remember oftentimes what the person who is personality B did or said. It's almost like if you think about going to sleep, you know, you don't remember what's going on in the world around you when you're asleep. The experience of having dissociative identity disorder is very similar. People, it's like you just black out for a while and you come to again, and you've said things and done things that other people, you know, read and interacted with you in, but you don't remember it because it was a different personality. Often this is caused by stressful situations. In fact, it, evolutionarily speaking, might be an adaptation to trauma in some instances. So if you imagine you have some terrible traumatic event, a patient might develop a second personality to sort of shield themselves from dealing with that trauma. This is, again, an extremely rare psychological phenomenon, but there is some a theory behind it that this is what patients with dissociative identity disorder, or we'll call it DID, do, that they will develop a second sort of persona to avoid dealing with whatever crazy, terrible, tragic things happen to them. There is a little bit of controversy among psychologists over the validity of DID as a real quote unquote disorder. Some psychologists will say, nah, this is bogus. This is a combination of people being suggestible and you know, social influences and people kind of faking maybe a little bit, not really valid. But others will say, yes, indeed, this is a real, true, and problematic disorder that people do struggle with. Next, probably a topic that many of you have heard about, that you're familiar with, is eating disorders. And eating disorders are included in the DSM-5, even though we may not necessarily think of them as a psychological disorder. The two big ones are anorexia and bulimia nervosa. Anorexia being when someone feels fat even though they're not. And so they will starve themselves literally and drop significantly below a healthy weight because they just look in the mirror and they see fat. This is an example, this is sad, but this is an example of an anorexic patient who has just starved herself so much that she's literally skin and bone. It's highly likely though that unless this woman had recovered, she would look in the mirror in this present state and still think that she needed to lose a little bit of weight. It's very sad. Very often, usually found in adolescents, so teenagers around your guys' age, and almost entirely female. Very, very few, although there is a such thing as male anorexia, but again, 90% or so, 9 out of 10 patients are going to be female. Bulimia, also an eating disorder, and often does result in weight loss, but not always, because bulimia is a cycle of what we call binging and purging. Binging is stuffing your face with food, just eating a ton, just scarfing, sitting down and eating several meals at once. That's binging. But then after you're done binging, you purge. You go to the bathroom and you stick your fingers down your throat and you puke up everything that you just binged on. As you can imagine, this is obviously an extremely unhealthy lifestyle. The one difference, though, sometimes bulimia can be a little bit harder to identify because it's not like a bulimic person is just constantly dropping weight. Their weight will fluctuate a lot because of this binge and purge cycle. They will also have other physical symptoms. Very common in bulimics for them to have kind of rotted teeth and bad breath, because there's so much, if they're constantly puking, the stomach acid starts to eat away at their esophagus and at their teeth and result in issues like that. So that's one way to identify a person who might be bulimic. The third one, binge eating disorder. We think about this a lot less than the other two. Anorexia and bulimia get a lot of attention in the media and are talked about and thought about a lot. But really, as you can see at the bottom here, binge eating disorder is the most common of the three. And it's just like bulimia, but without the purging. So you just can't stop yourself from eating. You just love scarfing food. You can see the stats here. Again, these are the percentages, commonalities of each of these. Binge eating disorder, we could say too, has some very serious cultural influences. You know, in the United States of America, we value big portion sizes. We love our fast food. And that all feeds into this idea of binge eating as something that is valid and that people do and that is acceptable in our world. There's a lot of research into what causes eating disorders, and there's been a lot of different findings. The first one is that specifically mothers, if a mother is preoccupied with her daughter's weight, that daughter is much more likely to have an eating disorder. So mothers who are constantly like, oh honey, you're a little heavy, constantly fretting about their daughter's weight, that's likely to cause an eating disorder. If a person has been around obesity a lot, they're more likely to have an eating disorder, especially in their immediate family. And eating disorders often happen with the quote unquote type A personality, meaning people who are very driven, very high achieving in school, in their work life, what have you. If their families mirror that. So if you're one of those people, if you're from a competitive or high achieving family, you're more at risk of developing an eating disorder. Lastly, I mean, we know about this cultural emphasis on being thin. This is more of a problem in some places than others. An example of this would be, back in like maybe the 1920s or so, it was actually, to be kind of chunky, to be a little tubby, was considered beautiful in the United States, both among men and among women. It was kind of like you were well fed. That indicated that you were well off, that you had a comfortable life because you could afford to eat a decent amount of food. And so it was valued and considered attractive for someone to have a little extra jiggle in their step. Of course, today that's very different. And corresponding with that, we see a lot more eating disorders now than we did back in those days when culturally we put less emphasis on being thin. As you probably expect this as well, those who have eating disorders intensely concerned with others' perceptions and thoughts about them. A last one, we'll look at personality disorders. These are fascinating. Personality disorders in general are inflexible, enduring behavior patterns that impair social functioning. So think about it. We think about personality, and when we talked about personality earlier in the year, we dealt a lot with psychological things, but when we're talking about personality disorders, we're really more in the biological realm. These are not the biological realm, the behaviorist realm. Excuse me, sorry about that. These are enduring behavior, observable behavior patterns that mess up, that make you less functional in a social setting. There's three clusters, so three categories of personality disorders. Those that deal with extreme anxiety, those that deal with eccentric or odd behaviors. And so the anxiety is stuff very similar to anxiety disorders. The eccentric or odd behaviors kind of just, you act weird, long story short. And then the last one is dramatic or impulsive behaviors. This is like over the top displays of emotion, displays of enthusiasm. And impulsive would be, you're given to randomly do crazy stuff with no real sort of forethought or prior planning. The most interesting and scariest, I guess you might say, is antisocial personality disorder. When we talk about our psychopathic killers, these are the people that we are talking about. This is one of our psychopathic killers on the right here. If you have antisocial personality disorder, that is a lack of conscience for wrongdoing, even towards friends and family members. The expression, you know, he'd cheat his grandma to get a buck. That's these people. They have no conscience driving them. Just like schizophrenia, this usually affects men. You know, we talked about the reasons for that, the genetic reasons, in our TED Talk video that we watched on Monday. Typically, this is going to start to manifest, which means it becomes obvious. You can see symptoms before the age of 15, so very young. And while it often leads to extreme criminal behavior, it does not always. But again, sort of for our purposes, especially as we think about our the insanity defense and how we're working with it, we're dealing with those folks who do become criminals, specifically who become killers. We're about to watch this clip of a patient with antisocial personality disorder. This is a famous guy, the Iceman. He was a hitman for the mafia. Just before I hit play on this, a couple thoughts. There's going to be some violent stuff in here. If that bothers you, you know, seeing there people shot up, feel free to skip ahead. If likewise, they're going to interview this guy and he is really creepy. Some people might find it disturbing. If that was going to really bother you, again, feel free to skip ahead. You can probably imagine how this is, but I think it's useful to see sort of a patient with antisocial personality disorder, talking about their symptoms. This is part of this is actually an entire 45-minute documentary about this guy. If you YouTube it with this, so if you like what this few minute long clip that I show you, YouTube and watch the rest of this. It's disturbing, but it's also fascinating to see how this guy's mind works. So I'm gonna hit play again. Fast forward to 3 or 4 minutes if this is not your cup of tea, if you think it'll freak you out. But otherwise, take some notes and consider this man's example as you think about your own recommendations about the insanity defense. Here we go.
Richard Kuklinski, a contract killer known as the Iceman.
Sorry, guys.
Richard Kuklinski, a contract killer known as the Iceman, is serving multiple life sentences for over 100 murders. He freely admits to the brutal, cold-blooded killings. But one question remains unanswered. Why?
Did you think of yourself as an assassin?
Assassin? Sounds so exotic. I was just a murderer.
In July 2002, Dr. Park Dietz, a world-renowned psychiatrist and consultant to the FBI, visited Kuklinski in search of an insight into his twisted criminal mind. Over the course of 4 days, Dr. Dietz spent 13 hours with him, trying to penetrate the psyche of this remorseless killer.
If I understand you correctly, you're positive you killed more than 50 people, and
Definitely.
you think you probably killed more than 100 people.
Definitely.
You're sure of that one,
Definitely.
but not sure it's more than 200.
I wouldn't say definitely to that.
Maybe yes, maybe no.
I would say less than 200 people.
Well, you tell me.
It's not less than 200 people.
You killed more than 200 people.
Sure. Yep. I killed basically more 100 people when I was a young man, before I even knew anybody. Too much. One part of my life, I killed people for nothing. Just for somebody to look at me wrong, I would kill them. Stab him, shoot him.
You tended to shoot people up close and personal.
Definitely. I wanted to tell them just before they left.
Richard Kuklinski, a world-renowned psychiatrist and consultant.
Stab him, shoot him.
You tended to shoot people up close and personal.
Definitely. I wanted to tell them just before they left. I wanted to say goodbye.
Notice how he reacts as he talks about this. He's got no sense of guilt, no sense of empathy with these people. It's almost like he finds it amusing.
Did you like to look them in the eye?
I wanted them looking straight at me. This was a long way away. The distance we are now. We were closer.
What did you want them to think as they died?
Just see my pretty face. I take it to them. But the last thing they ever saw was me. And if they carry that glimpse to eternity, infinity, or whatever it is, they're going to be thinking of me all that time. I'd be looking in their eyes. I would see the blankness come over it. I'd watch them die. I just didn't shoot them and walk away. I saw the surprise, the shock, the blank. They're gone. And all I saw was my reflection. But that's it.
Did you have a favorite place you'd like to shoot?
A favorite? Well, most of the time, if you're up close, you shoot them under the chin. You would shoot them. Shot a guy one time in his Adam's apple. See how long it would take him to die.
How long did it take?
A few minutes. He drowned, actually. He didn't.
Drowned in his blood.
So obviously, you kind of get the idea, no remorse, no guilt. It's just like a thing he does. He finds it almost fascinating, these serious acts of violence against other people. Again, I'm pausing to hear there's 45 minutes of this, and they cover a lot of different ground about what it's like sort of going on inside his mind. You've got the YouTube title up here if you want to search and look at it on your own. So what causes antisocial personality disorder? We talked about a lot of this in class, so I'll go over this kind of quickly. It is heritability, but we don't have that one clear gene. We did talk about the MOMA gene with the TED Talk that we watched. It is kind of more of a cocktail of genes than just that one, though. Lack of stress hormones and autonomic arousal, but an increase in dopamine flow. So we did talk about serotonin in class. This is some other related symptoms. A person who is antisocial doesn't get that stressed. The things that would stress out you or me, it doesn't really bother them that much. Similarly, they don't really get aroused in the way that we mean psychologically. Again, we're not talking about sexual arousal. We're talking about heart rate, breathing. Do their pupils dilate? It just doesn't really happen for them. They're just kind of even keeled. But when these acts do occur, they do have an increase in dopamine flow. And remember that dopamine is strongly linked to feelings of pleasure in our brain. There's less frontal lobe activity, less ability to empathize with other people, less response to facial displays of distress. They just don't read those sort of distress displays in a person's face like you and I would, and they certainly don't attach emotion to it. And the last one is that very often these people were mistreated in childhood. We talked in class about how many of these people had seen violence, like a psychopathic killer, very likely to have been exposed to some violent acts in childhood. Similarly, it's very likely that they were mistreated or abused themselves, and that has contributed to the development this disorder. That concludes our videos. Make sure you post that one last question on Google Classroom. Looking forward to seeing the rest of your presentations tomorrow in class. Have a good night.